You're listening to the Medic Materials Podcast, hosted by Mike Turek, Emily Yates, Kelsey Coons, and Gerard Cuomo. Each month, we discuss EMS news, medical science, and review actual EMS calls, bringing many educational opportunities to the listener. Portions of the calls have been altered to protect the privacy and identity of all involved.
Hello and welcome, everyone. How are you guys tonight?
Doing good. How you doing?
I'm just peachy. Miss Emily, how are you?
I'm good. How are you guys?
Awesome sauce. Get all this new stuff adjusted so I'm actually in the box. Can't be, outside the box. That'd just be weird. Mr. Maha, you look bored in your box.
No, just tired. It's been a long week already. It's only Monday.
It's only Monday. So
last week led into this week.
Oh, did it? I worked extra, which I don't do because my wife makes all the money, and so I worked Sunday like normal. Then I picked up a shift Wednesday and Friday, and then I worked another Sunday, and I think I threw a Saturday in there the previous week. And
are you feeling okay?
I know, right? Exactly. And I'll tell you, I got my ass handed to me on Wednesday. I got my ass handed to me on Friday. I'm like, this is why I don't work any more than normal. This whole extra shift thing is non-healthy. I don't know why people do it. It's just not healthy. But yeah, so today I'm going to ease your guys' pain. And I'm going to say today is probably, I have one of the easiest calls that we have ever done.
It means we're going to overthink it like crazy.
Probably. This call is so easy that I actually was kind of skeptical on even putting it on here because it's just not what we typically talk about.
They died. You're welcome. Have a good night.
However, I was thinking to myself, going, all right, there's some really good, BLS badassdom in this call. There's a lot of good assessment in this call. There's a lot of everything just goes well in this call. So I think you guys will handle it just fine. I think you'll get it as soon as I say the first thing.
You know, I'm a paramedic, right? We don't do BLS.
Well, that is something to think about, right? You might
never heard a truer statement.
You might overthink it then.
That's why we have badass EMTs, so that we don't have to do those basic things. We just go do your thing, I'll do my thing, and
That's for damn sure.
Meet in the middle.
Yes, meet in the middle. That's why it's a great partnership. Such a great partnership. So
that's why it works when it's a great partnership.
That's true. Because if your partner sucks, well, then you're shit out of luck on that. Yeah, you're just fucked. So let me do again Kelsey's job with the rig check, and
damn it, Kelsey.
I know we'll get started here. So as I did last episode, guys, I want to urge you guys to continue to share, rate, and follow the podcast. The grassroots growth of the show is how, I don't advertise this show, right? There's no Facebook ads that you're going to see going, hey, follow Medic Materials and watch us on the podcast. Nope, it's all you guys. So being able to sharing, you guys share it on social media, tell your friends, tell your coworkers, listen to it while you're working. That's all awesome, and that's what we really want to hope that you guys continue to do for us to grow the show. If you feel like not doing that, I'm going to give you the same thing. Become a $5 Patreon. You get a lot of cool stuff. You get a CME credit every other month, as well as a third Patreon exclusive podcast, which the next one is going to involve a bear. So that should be really fun. Yep, the next one that I'm writing right now, when we record it, will involve a bear. So, yes, lots of fun to that. And if you're allergic to all of that, you can always just tip the show and tip the stream. The link is down in the description below.
Buy some merch.
Yeah, you could always buy merch too. You know, I wasn't going to throw that in this time. I want you guys to understand that if you're a listener in New York State, you can get CME credit for listening to this show. So go over to www.medicmaterialscmeacademy.thinkific.com. Again, you don't have to remember that. The link is in the description of the show. Go over there, and every single, well, not every single, but the first season of the show, the second season, and part of the fourth season are all up right now. You can go, you can listen to the shows, and you can get BLS CME credit. So, like, that's kind of a no-brainer. Listen to us in the car, while working out in the gym, while at work, and earn CME credit for having fun listening to us. The last thing I want to do is shout out our listeners in the great state of California and Australia today. And I timed that perfectly. Boom.
You did.
That was
well done.
Epic. That was epic. I've never done that.
Wow.
That was really cool. That was awesome. I'm going to give myself a yeah for that. So, all right, let's jump right into this call because again, we're going to have a lot to talk about after the call. I think there's going to be a lot to talk about in terms of anatomy, physiology, maybe some pharmacology. I think there's a lot to talk about. So the call takes place in a small city of about 6,000 people. The city's covered by a private paid town ambulance that runs 4 ambulances per day, typically in the standard EMT basic and paramedic configuration. However, today, during this call, all the ALS units are busy. So the company only has a BLS rig with 2 paid EMT basics. That's who's going to be responding to today's call. There is hospitals in the area. There's going to be one small city hospital. It has just generalized capabilities, nothing crazy. All right. That is going to be 4 minutes away from the scene. You're also going to have a cardiac center about 45 minutes away from the scene. You guys are dispatched to a local apartment complex for a 32-year-old female with complaints of shortness of breath. Again, all of the ALS ambulances for that company are currently on calls within the district. So the BLS ambulance calls en route, and no other mutual aid ambulances are sent because the BLS ambulance goes. Okay? So no one asks for any paramedics. Nobody sends any paramedics. No nothing. You guys can just ask for that later. So while this crew is en route, the County 911 dispatchers updates this responding BLS crew, and they say that they've lost verbal contact with the caller. The line is still open, but it sounds to the dispatchers like the shortness of breath is worsened. Now they're calling it severe shortness of breath from what the sounds they hear over the call. The county dispatchers say they are completely unaware if the caller is still conscious or if they're now unconscious at this time. So if you guys kind of get this dispatch and your BLS, right, and then you get this update and you got a 4-minute ride to the hospital, at least the generalized, community hospital, where's your thought process already going before you even get there?
My closest advanced airway is 4 minutes away.
Right.
Yeah. Right. Like I have to manage a BLS airway until I can get to the advanced airway, which is going to be the hospital in this case. Like
But if you think about it, like your initial steps for severe shortness of breath, whether they're 30 or 60, the first 5 steps are the same, ALS or BLS. So I can get that in 4 minutes. And I can get to a hospital where they can get everything else that I can't do. But in my mind, my closest advanced airway is 4 minutes away.
Right. Mr. Ma, do you have anything to add to that?
I mean, obviously, you start hearing a more severe patient, I would start trying to pull out to see where my closest mutual aid.
Yeah.
If I have somebody within 4 minutes or closer, maybe try to get them to me. But otherwise, I'm going to know that it's going to be a shit and get kind of thing. Stop and see if it's serious. Then we're going to that 4-minute hospital.
Right. And
maybe you're lucky and there's an ALS crew at that hospital that's ready to turn over.
Right.
yeah, right. And I guess seeing where those ambulances are, because who knows, mutual aid, like we don't know this district. Mutual aid literally might be 10 minutes away. Right. Or they could be 30 minutes away. We don't know where that ALS is coming from. It could be the hospital. Right. So I kind of get in the thought process, and we've talked about it before, where like severe patients for a BLS provider, that is a load and go situation.
Mm-hmm.
Whereas like a severe patient for an ALS provider is more of a, all right, let's hold off on running, let's stabilize and then run.
Right.
Like, so the roles are backwards depending on what provider you are with that serious patient.
And
So
like you said, all the other ambulances run on calls, but if one of those calls is not an ALS level call, maybe that
But
BLS
I mean, you have
drop
to,
that when it goes.
you show up on scene, you assess, you extricate out. It's a 4-minute ride to the hospital. Maybe 10, 12 minutes, 15 at the most.
yeah, depends on.
So
yeah,
you have to be closer than 15 minutes for me, because my fear is that a lot of the BLS providers are gonna be like, oh, that medic's 10 minutes away.
and then
I'm
they
gonna
wait.
call them after I assess, and now I'm waiting an extra 10 minutes when really I could be to the hospital in 5.
Right. It makes no sense to wait in this situation unless they like get there and this person's coding. Right? Then you could sit there and be like, oh, okay, well, I have to work this for a little while before I go. So yeah, you got time, But yeah, I mean, even if there's calls going on that, other ambulances are doing, they could RMA them. They could no patient them, right? Who knows what they could get canceled before they even get there, right? We don't know. Maybe it was, an alpha priority 4 for a medical alert, and it just so happened that a paramedic went, So going forward, the BLS ambulance arrives on the scene. The 2 EMTs gather their first in bag and their stretcher, and they enter the apartment complex. They make their way to the apartment, knock on the door. The door is answered by a young child. The child shows the providers into the apartment and to their mother, who is sitting in the living room, leaning over in the tripod position, appearing in significant respiratory distress with audible wheezing and stridor that you can hear from the door. Any thoughts on that?
We've got some airway issues. We need to start treating with, they have albuterol, so maybe albuterol.
Oh, I think aggressive airway management in this is probably prudent for these EMTs, right?
I don't know what their protocols are where they are, so you know what they can do. I mean, albuterol, maybe some CPAP, but what they can do. So
right. These guys are CPAP trained. They are albuterol trained, so they could do both of those, right off the rip if need be. So the primary EMT steps in, introduces the crew to the female patient, and they immediately begin their primary exam. They find that her airway is clear of fluid, clear of debris, but it looks slightly swollen behind the tongue. There's audible stridor present. Breathing is extremely labored. They note visible intercostal retractions and accessory muscle use on each breath. Lung sounds show wheezing in all fields bilaterally. Peripheral pulses are weakened and fast, but present. Skin is super, super, super pale, clammy, and covered with large pink rough blotches across the entire body. They also note that there's smaller, smoother red blotches to the arms, neck, and torso. So I'm going to pause here, get your guys' thoughts, And then I'm going to ask, where do you want these guys to go forward? I like the awkward silence. We're waiting for Gerard to answer.
We're waiting. I was just going to say that. We're waiting on Gerard.
So now it's up to the Maha to answer, because we know Emily's not going to go first.
From the advanced from the advanced point of view, I mean, CPAP's a good idea. I'm gonna be careful of albuterol because I don't want this one to flash on me. Just knowing what I think is gonna happen, you know what I mean?
Yep.
So, but being that they have albuterol, this is their only line of really treatment at this point in time. That's probably what they should probably do. But
and we don't know any type of like history. We don't know if this lady's on any meds, has any allergies. Like, we don't know anything about anything other than it looks really bad right now. Like, really bad.
But how she's presenting right now, this sounds like a CHF exacerbation going to be happening on us pretty soon.
Okay.
You know what I mean? So the albuterol treatment, you could be working on a flash.
Really?
Yeah, I mean, diaphoretic, blotchy skin. Like, she's
I'm getting allergic reaction vibes here.
So I like, okay, because right now in the chat is throwing out anaphylaxis, asthma. The Maha is throwing out CHF. Emily, you're going with anaphylaxis as well, or, you know, allergic reaction. Where's the thought process there?
I'm just thinking like the hives, the wheezing. You know, I think as a BLS provider, I would think twice about the albuterol, because if she's having an allergic reaction, I don't want to stress out her anymore. But I think I'm also still going to give it because I think that will help her breathing. We're going to fix one problem at a time. But like, I want a little more history to see if she has any known allergies. Is there any exposure? You know, with the hives, the wheezing. We haven't gotten vitals yet, but
I like both thought processes here. So you can't just like immediately go, okay, this is this.
One, right.
You know,
right.
I like keeping like all of them, even asthma. You know, like
yeah. I mean,
even that, right? This could be, who knows? This could be a PE for all we know at this point. You know, like we don't know, right? But that stridor makes me kind of lean in the direction of and the airway swelling. Why is that happening? Right? That's the kind of thing that's like, this doesn't fit in the whole, you know, picture. So you also, I don't know who it is, but there's someone watching on Facebook that says, I'm with you, Em. So you at least got one person in your corner for anaphylaxis.
Hey, me and you, we'll be a crew. We got it.
So the secondary EMT begins a full set of vital signs, while the primary EMT takes the pulse ox probe, places it on the finger while getting out the oxygen tank because they want to get oxygen on this patient. So vital signs return, blood pressure via the manual cuff as 86/50. Heart rate is weak and fast on palpation. Rate returns is 138 via the pulse ox probe. Respiratory rate is, again, very labored, very shallow, in the mid to upper 30s. SpO2 on room air returns is 82% and is falling in front of providers.
Did the cops give her Narcan yet?
16 milligrams. Funny you should ask.
This is a city, so you know they probably like are there itching to do it. GCS at this GCS at this point is a 14. She's alert but confused and becoming tired.
Oh,
I hate
bringing up
tired.
30 a minute.
So,
And her heart's doing a marathon right now.
and her heart's
Literally.
right, and she's beaten at 138 with a falling pulse ox of 82. So it's probably in the 70s.
I mean, kudos to them. I don't even think I would have put her on the pulse ox before I put her on oxygen. I don't need a pulse ox to tell me that she's short of breath.
Right. But
I don't care what the room air stat is. I don't care.
But how many times have we walked into the stupid hospital and they're like, what was their stat on
The room air stat.
And I'm like, who cares? If I waited to figure it out, they'd be dead.
I am that person, but it's because you turn them around so much by the time they get to the hospital. I'm like, there's no way they were this sick 5 minutes ago.
I mean, true that, but you know, at least they were doing it simultaneously to other things. Like, they didn't sit there and go, okay, I'm going to wait and see what their stat is to see if I need to put them on oxygen. They were like, let me put this on and let me get the oxygen going.
Bullshit. You know they unraveled that cord and turned it on before they even grabbed the oxygen tank. You know it.
Probably.
Bullshit.
Untangled all the lines for...
Literally.
You know.
Yep, probably. I'll give you that. So this primary EMT placed her on 15 liters via non-rebreather mask, then attempts to get the story of what the heck happened to cause all this difficulty breathing and to make it this bad. She's speaking in 2 to 3 word sentences and literal huffing to get words out. And remember, like, we still have to remember there's audible wheezing and stridor still present during this conversation, right?
Yeah, I don't know. I think I'm asking yes or no questions. Do not talk. I'm getting meds right now.
Right? Just nod at me,
yeah,
please.
Don't waste your breath.
So I'm 100% with you, right? And they kind of
walk down all these flights of steps and get on my stretcher.
That's what I'm waiting for, right? Can you walk to the ambulance? Just, you know, I don't feel like picking you up and moving you. So this patient tells the crew in these 2 to 3 word, super huffy, you know, sentences that she took a shower, felt scratchy after, then abruptly felt short of breath. Symptoms came on about 15 minutes post-shower. The providers then ask her, like, medical history at this point, and at this point, she just stops talking and just goes to nodding. Like, she herself is like, fudge this, I'm not talking anymore. Like, I'm just going to nod at these people who keep asking me to talk. And she nods no to any respiratory history, no to any cardiac history, no to any diabetic history, nods no to taking any meds, and nods no to any allergies.
Oh, she has one now.
That's all they ask.
Figure it out, man. You were allergic to something you took in the shower.
So, all right.
Got a new body soap?
So you are really in sync with the chat. I literally just...
I'm on this allergic reaction thing. So whoever's my partner, we're in this together.
So again, some WW2 girl says something in the soap, or did she eat something that she was allergic to before she went in the shower?
Right?
Power
snack.
Power snack.
She got shot by the magic bullet.
She's about to.
That was such a good episode. So yeah, what, like, M, you are firmly grasped on
I think I'm like
here?
sold allergic reaction right now.
Okay.
I also think she's 32, no medical history, no cardiac history. I think I take my chances with the epi. I know her heart rate's 130. You know, you can do the albuterol for the wheezing and all that, but I think that the epi is going to fix all of that for us.
Okay. Mr. Maha,
so
where are your thoughts here?
So have we ruled out sudden onset of chest pains, any of that fun kind of stuff yet?
They haven't specifically asked about chest pain, like any
all she has is no cardiac history.
Right. She nods no to a cardiac history. And
30s. Is she a smoker? Is she on, birth control, PE, stuff like that? You know what I mean?
I mean, it still could be a PE, but with the hives and the stridor and the wheezing, I don't think so.
I mean, I could understand like a PE might give you some residual wheezing. Like if
not
there's
like this, not in all fields.
Exactly.
Yeah, I know. I'm just saying it's something we still have to factor in a little bit. But yeah, I understand the wheezing and all the fields and
right. I'm leaning more towards the the allergic reaction just because she's hypotensive.
Tachycardic,
this came on
hives,
sudden.
stridor.
Right. Like
sudden onset.
Right. You know,
Yeah.
and we got to remember, like, so there's multiple different types of blotchiness on the body, right? So there's like what they described was really large, like I'm talking large patches of like rough blotches, and they're scattered from head to toe, right? And then there's little itty bitty blotches that are and those are smooth. Those are solely on arms, neck, torso. Nowhere's else.
When you first said it, I thought you were talking about petechiae. That's why I went,
Okay.
the first way I went. But now that you're said, yeah, okay.
So like there's a couple different types of stuff on the skin, and we'll get to that later on. What exactly all that stuff on the skin was. So your partner on Facebook is in total agreement with what you're saying. So you guys,
them and I, we're given epi. This patient's going to turn around. We'll see you in 4 minutes.
right? Still extricate, get out fast. Boom,
Yep,
we're at the
bye.
hospital.
8-hour observation at the hospital. Goodbye.
There you go. So the primary EMT looks at their partner, tells them, hey, listen, I think you need to grab an EpiPen. And they literally say, listen, grab the EpiPen. I think that she's suffering from an unknown type of allergic reaction. Their partner hands them the EpiPen, but asks them like, hey, are you sure? Like,
Pretty positive.
I kind of want a discussion here. So the primary EMT does a really good job in this discussion. And they note that there's wheezing, right? In all fields, there's the stridor, there's the presence of the swollen airway, right? There's the red marks on the skin, the lack of any respiratory history. And the secondary EMT goes, all right, I'm good with all that. I'm okay with this. I think you're going in the right direction. So primary EMT looks at the female patient, tells her, listen, we're going to administer this IM EpiPen. And due to the belief that, she is having some sort of allergic reaction, they walk her through the process and they smash the EpiPen into the large muscle in her leg.
At least they didn't do it in their thumb.
Oh, that would be so bad. That would be something that would be on this show.
Yep.
So at this point in time, the secondary EMT moves outside of the apartment to bring in the stretcher and begin that whole extrication process. About 6 or so minutes go by. The EMTs have now helped her onto the stretcher. They've grabbed the child's car seat because, again, remember there's a child involved in this whole thing, and they're moving out of the apartment and towards the ambulance. While walking through the hall, the primary EMT notices that her breathing is slightly improving. She's taking a little bit fuller breaths, less shallow, with audible wheezing, and the stridor is minimal at this point, but still present.
Okay.
They get her outside to the ambulance. Primary EMT goes ahead and gets another set of vital signs. If anyone's actually watching this stream and wondering why I'm getting shorter, it's because my goddamn chair is lowering on its own and it's driving me fucking crazy. Ugh. It's like I'm turning into an Oompa Loompa.
Throughout the show.
Oh my God. And it'll keep doing it. Like, I don't know how to make it stop.
So you buy a new chair.
This chair was fucking expensive. Like, I don't want to buy a new chair. It's so comfy. So primary EMT, once they're inside the truck, gets another set of vitals. Manual blood pressure returns as 102/86. Heart rate stays in the 130s, surprisingly, with the epi. 130 strong and regular. Respiratory rate comes down, 24, less shallow, almost no use of intercostal muscles. SpO2 of 91% and holding still on the 15 liters non-rebreather. Lung sounds are retaken, found to still have wheezes in the bases only, bilaterally. Apices are clear at this point in time. GCS is recalculated. It's turned out to be a 15. She's alert. She's able to speak. She's awake. We're all good there. So to me, it seems like the EpiPen has done something to improve the situation. So what do you guys, as this BLS crew is about ready to get this patient, transported, what do you want to see? Because they're going to the local hospital, right? It's literally only 4 minutes away. What do you want to see in that 4 minutes from these guys? And we're still looking at Gerard.
Keep assessing your patient. Obviously listen to lung sound,
Right.
oxygenate, if need be, ventilate. At this point, you could try some albuterol. But I think it's a moot point at this juncture because the epi seems to be working. So
Okay, M.
No, I agree. I think you need to do constant reassessments, constant vitals. I think that the epi worked, but I don't, she's not cured yet. So I think she could turn around pretty quickly if that was going to happen. So you need to do constant reassessments.
Well, and that's the
Still got
one.
4 minutes.
Well, and that's it. You got 4 minutes, right? So
Yeah.
it's not a lot of time, but it's enough time
But it
that
is.
something bad could still turn and happen. Like you could be doing just
Yeah.
fine, and then boom, they're dead, and you're like, whoa, what just happened, right? But my thought process is yes, assessments, lung sound, stuff like that, but they don't have the ability to further stop the allergic reaction. Like they don't have Benadryl, they don't have
Benadryl, steroids.
right? They don't have that, but they do have the albuterol. Like I kind of want to see them go and just be that aggressive and fix the end of the wheezing. I want to see them do that. Because they don't have all the other stuff,
Isn't
I'm not against it.
Isn't the protocol they have to have a history of something, or is it just have wheezing?
So for at least in New York, if you want to give albuterol as a BLS provider, you have to have a COPD or an asthma history, unless there is wheezing present in anaphylaxis, and then you can give albuterol.
Right.
So if you just want to give it oh, hey, I have a patient who's difficulty breathing, they have to have wheezing, they have to have COPD or asthma. If it's anaphylaxis and there's wheezing present, you can go ahead and give it after the epi, if there's still wheezing present.
I feel like I would go for that because there's nothing else I can do right now. As a BLS provider, I can't do jack shit for this allergic reaction besides what I've done. So I'm going to give it regardless. She's 32. She's got no cardiac history. I'm not worried about it. Her heart rate's still 130. We just gave epi and she just had an allergic reaction. I do not care about that.
Right. And if she goes up to 150, okay.
Sucks.
Who cares?
She's the one person that we take care of that can probably handle it.
Right. So the ambulance begins the transport. Local hospital, only literally 4 minutes away. Primary EMT asks her again about any history or allergies she might now have that she can finally speak clearly. I think this is a really good thing to do. Going back and asking those questions now that she can actually speak, right? She tells them that she has a history of psoriasis, but nothing else. She uses a steroid cream for the psoriasis, but denied any allergies that she knows of. The EMT then asks what occurred prior to feeling short of breath. And she tells them while she was in the shower, We'll hit again on that one. While she begins to answer, the EMT moves to switch her from the non-rebreather to the albuterol neb for that continued wheezing. And she goes on to say, listen, there was nothing out of sorts through the morning. She woke up. She ate with her kid. She played with her kid. Then she went in to take her shower. About 15 or so minutes after the shower, she no longer could breathe. It was that sudden. No, Rubble, I don't want to play with the tire right now.
Oh, poor Rubble.
He's putting his tire right on my lap as I'm talking. She felt as though she was like, she says to this EMT that she felt as though she's being suffocated and was covered in more red blotches than normal. So remember, that difference between those two red blotches we were talking about, right? There's psoriasis blotches.
Aren't the big ones like chronic? The little ones are like the acute urticaria.
So in terms of this patient, the larger rough pink blotches are her psoriasis blotches.
Yeah.
Right? Those smaller, smoother bumps are the acute hives from the allergic reaction. So when she, started feeling like she was suffocated and actually starts getting covered in more of these red blotches, that's when she goes and calls 911. So the EMT doing their, thorough questioning asks all of the questions like, hey, did you use a different soap? Did you use this different, did you wash your clothes in anything different? All this stuff. Anything used different during or prior to the shower?
Psoriasis cream.
Nope, that hasn't changed.
Oh.
She's using the same steroid cream. So she reports that she used her normal soap, but she used a brand new loofah. She typically uses she used a natural loofah all the time. But in this case, she ran out of her last natural loofah, ordered more online, and is waiting on that shipment to get to her house. So she just went to the dollar store, bought a cheap one to hold her over, and used that during the shower. So that is the only culprit that these two can think of that might have caused all of this allergic reaction. So with the neb going, they take another set of vital signs. This is the last one for the call. Manual blood pressure returns as 110 over 90. Heart rate stays 128, strong regular. Respiratory rate drops to 22, again appearing regular. SpO2 of 96% on the 6 liters albuterol neb. GCS of 15. So ambulance arrives at the hospital. She's offloaded. Handover report. Back in service. Fairly
They gave her
straight.
Benadryl and Pepsid and steroids, and they watch her for 8 hours.
What? So hold on. They give her steroids. What was the second one? Pepsid?
They give her Pepsid. You get famotidine, Benadryl, and Solumetrol.
Why would you get... Oh, fuck you, Phil.
It's a histamine blocker.
Goddamn freaking Phil Foundation. I swear.
Goddamn Phil.
Now I'm going to have to fix this, Phil. You screwed everybody up but Emily.
You want me to leave?
Thanks, Phil.
No. Are you going to stay the whole time? You're back from work?
I am.
Okay, so be right back, everybody. Let me go fix what Phil fucked up, and we'll be right back. Mr. Phil Foundation, now you're in the stream.
All right, cool.
32-year-old allergic reaction. BLS crew gave epi and albuterol.
Okay.
Yep.
You're caught up.
You are immediately caught up. Look at that. Boom.
Out fucking standing.
Look at that.
Boom.
Boom.
Boom. It was a killer loofah. Seems to be
it was a killer loofah.
Yep, absolute killer loofah.
What?
So the girl had always used natural loofahs, and she ran out. So she bought more natural loofahs on the internet, and they didn't come in yet. So she went to the dollar store, bought like a regular loofah from like whatever loofah company, is in the dollar store, scrubbed it all over herself, now has allergic reaction.
What the fuck is a natural loofah?
It's a sponge.
It's a sponge.
It's a sponge.
I know, but
Like
Google it.
what makes it natural?
That it grows out in nature.
It's a
They
real
literally
sponge.
take a sponge from the
It's
ocean
organic.
and dry it out, and it becomes
Okay.
a
All right.
loofah.
All right.
You should know this, Phil.
How
Like,
the fuck should I know that?
because you know everything. And now I'm going to pick on you even more because you interrupted the show and made me do work.
You said when I got home, join the stream.
No, I didn't. I said, when you get home, text me and I'll let you join end of tour.
He did text. He did text.
Oh, see, I have my phone on silent. So,
Oh, I got it. It said, I'm home.
Yeah, it was right up on my thing. It said I'm home. It was right there. I saw
Yeah.
it.
whoops.
We
Mic
both
drop.
got it.
Yep.
Yeah.
Whatever.
Sounds
It's all
like
Turk's
somebody
fault.
doesn't want me to be part of the fucking podcast anymore.
Oh, shut up. So, anywho, Emily, you were talking about why they give Pepsid.
It's
So,
a
like,
histamine blocker.
is it?
So you give Pepsid to stop like indigestion and GERD because it's a histamine blocker. So you're giving at the same time an allergic reaction because there's nothing in Pepsid that says, oh, I'm only going to block this in the GI tract.
See, I never realized that that was a histamine blocker. That's really
Yes.
interesting.
Yes.
Intriguing. So, yeah,
And then you sit there for 8 hours and then you go home.
which
Maybe
I mean,
you get a second dose of Benadryl. Who knows?
which totally makes sense. Yeah. All I have is that they were given steroids and Benadryl along with one more breathing treatment and then released.
I bet they were given Pepsid and the EMS crew was like, what the fuck?
Right?
And didn't put it in.
Yeah, probably because again, that's the first time I ever heard of that. So that's pretty cool. But so Phil, being at the end of the call, you didn't miss the important things that we were going to talk about because I told these guys this was going to be one of like the most straightforward calls we've ever done on this show. Would you agree it was fairly straightforward, guys? Like
It was
if
pretty
this was
straightforward.
like if you didn't get it, whack.
Also,
If
Heather and
if
I from
had-
Facebook were all over this.
If I hadn't misheard you in the beginning, I would have, if I was paying attention at the beginning, it would have been all right.
That's all right. Blame it on your chair.
You not paying
I
attention.
blame it on your
Brooks?
chair.
Really?
You're the one going up and down.
I know my chair. It's being good right now. It's being a good chair. It hasn't lowered me to the floor again. So, I want to talk about two things. I want to talk first about just the actions of what happens during anaphylaxis, why epi was the right choice in this. But then I also want to talk about the pharmacology behind why we give the Benadryl, the steroids, the epinephrine, and the albuterol all in conjunction for the allergic reaction. So like in the alert, like when somebody has an allergic reaction, right? You get leaking from everywhere. So think about like your body is trying to fight off an invading organism, this allergen, right? So your immune system goes, hey, I need to get it. I need to kill it, right? So it goes and it says, hey, I need more help. So it says, I need mast cells. I need, all these antibodies. I need all of these things to come in and fight off all this stuff. The problem with that is that also releases all of these different chemicals. Again, I made a beautiful YouTube video on this so that you can go and watch it, where I literally draw out the entire thing. But these chemicals will literally make holes inside of the walls of your vessels so that all of the fluid goes from the inside of your vasculature to the interstitial spaces. This is how you get your swelling. This is how you get your hypotension, right? That fluid shift, because those white blood cells need to get at the allergen inside the interstitial tissue to be able to kill it, right? So that's how all of this happens. And it happens not
Making
just like,
space.
right, it doesn't just happen in your pinky, it happens systemically. That's why it's such a problem, right? So if we know that, right, and this histamine release is what causes this, right? This massive histamine release is what causes this. So we want to first, if it's this bad, we want to give an epinephrine. We want to give a alpha beta 1 beta 2 agonist to work on fixing this whole fluid shift problem. Because I know that Emily's itching to talk about epinephrine or any of these drugs, I'm going to let her. No, you are. I see it in your eyeballs. You're itching. You're leaning forward, itching to talk about it. So I'm going to let you talk about epinephrine and the alpha.
I don't know. What am I going to talk about?
You're going to talk about the alpha properties of epinephrine. That's what you're going to talk about.
I mean, when you think of epinephrine, you always think of it as another pressor. So like you want it to compress those vessels to keep all that fluid in. It's also closing those holes by doing that. But what I was going to say is, like, remember when you're thinking about anything pathophysiology, like structure equals function. So why are my blood vessels leaking fluids? Oh, because it needs to make space for all these other cells to go and fight this allergen. Well, that's great to fight the allergen, but that's not so great for my blood pressure, my heart rate, and all these things. So, like, we need to fix that. And then we can give every other medication is going to fix this issue.
Right.
In its own way.
Right. And that's, you know, again, there's a system that we should be following, right? The most detrimental effect is that fluid shift, that permeability, right? That hypotension that occurs. So we need to fix that. The only thing that BLS providers carry to fix that is epinephrine. That's the only thing. So by giving that epi injection, you are clamping down on those vessels, right? That alpha 1 agonist is going to clamp down on the vasculature. It's going to close those holes. It's going to increase pressure, right? It also is going to help with that wheezing, right? Because it's also a beta 2 bronchodilator. So you're going to hit the lungs and open up all those lung passageways. So you're helping the lungs by an IM injection, right? Whereas if we wanted to give albuterol to do the same thing, that bronchodilation, it would just get stuck. It wouldn't get down into the bottom of the lungs because you have to inhale it, right? So I think that's what a lot of people go, oh, well, you know, why am
Let's give albuterol and then get the epi. There is a reason why you give the epi first.
Exactly, right? It will allow it to open those lungs so you can actually get the albuterol in second, right? Where we are attacking the problem 2 different ways, right? One through the bloodstream, one through inhalation. So that's something to remember, right? Benadryl. Why do paramedics give Benadryl, or why do you take Benadryl in an allergic reaction, right? It's a histamine blocker.
Histamine blocker, yep.
Right? So
it makes me feel better.
It makes me feel sleepy and great, and I love it. But we give that Benadryl solely.
It's not the best histamine blocker, but it's a histamine blocker.
Hey, for being
the one they give you.
For being an over-the-counter histamine blocker, I'll take it.
Works pretty well,
right? It works pretty darn well. But you get a paramedic on scene if possible to give that Benadryl, because that Benadryl is attacking the source of the whole problem.
The chain reaction. It's like the first link of the chain reaction that's occurring.
Bingo, right? The histamine causes everything, right? The histamine is what the mast cells actually release to call in all of the other things, plus do that permeability, right? So it's going to stop that from happening, which means no permeability, no vasodilation, nothing like that. Boom. Now you're on the track of doing better, especially if you gave epi and albuterol, right?
But it really doesn't make it better. It stops it from getting worse.
Yes.
Because whatever's already occurring is still occurring. You can't stop that with a histamine blocker. It's just it's gonna stop the reaction where it's at.
Right. I wholeheartedly think that's a way better way of saying it. Thank you, Emily. You get a yeah for that.
I love my pharmacology.
I know you do. That's why I figured you'd just take over and shut me up eventually.
No, I can't start it. I don't know enough.
Yes, you can. It's fine.
No.
Do you want the steroid or do you want Butch to take the steroid? How about Phil Foundation can take the steroid? Why do you give a steroid now in anaphylaxis?
Kind of put me on the spot here.
Yeah, well, you were late and you made me work, so fuck you.
Okay. Okay. Sorry, I need money.
Oh, he's got
to
both
live.
hands going now.
Yeah.
Oh, hey,
Oh,
hey.
yeah.
You never had a bread sandwich.
Don't you dare talk about my mother like this. You give the steroid helps open the lungs up. So after the epi, give the steroid, it prolongs that not respiratory drive, but it helps for like 72
Decrease
hours.
inflammation.
Thank you. That was the word I'm looking for. It's been a long day, okay?
I got you.
It's
I got
been
you.
a long
I'm
day.
here for moral support.
But it decreases inflammation around in and around the alveoli for about 72 hours if it's Decadron. I think it's like, what is it, 48 to 60 for Solumedrol.
I honestly don't remember.
And the Decadron actually acts a little quicker than the Solumedrol.
Yeah, I was gonna say reverse that because Decadron is.
He's saying
quicker.
how long it works, not how
Like,
quickly it works.
Yeah, but Solumedrol stays in your body longer. I'm pretty sure.
I don't honestly remember. We stopped using it 10 years ago. Friggin' yeah. It took too long because like the onset of Solumedrol was like 35 or 45
But
minutes.
45 minutes.
Yeah,
That's
whereas
That's why
like
I think
Decadron's like
Solumedrol
20,
stays in your system
25.
longer.
Yeah,
You didn't even see the effects. You get dropped the patient off at the hospital. You're back right your chart before they started feeling the effects.
exactly. So yeah, to build on that, right? You give the steroid, right, to help break that inflammation. So even if there's inflammation, and swelling in the airway, right, that's going to help decrease that a little bit. That epinephrine is going to help decrease that swelling because it's going to push that fluid back into the vasculature where it belongs and not into the interstitial spaces, right? So again, it halts the worsening. There's still going to be some swelling, but it will halt the, inevitable flow of all the rest of it. So, yeah, I think, I always say that EMTs are given enough drugs to actually save lives. Like epinephrine will save lives in anaphylaxis.
But it did for her.
And it
Because if
did.
they had not given epi, she would have coded by the time they got to the hospital.
Yeah, absolutely. Respiratory failure, 100%. Yeah. And in this case, being that aggressive, they didn't need to do CPAP. They didn't need to BVM her. They didn't need to do anything like that. They recognized, hey, I need to do this and went with it. I loved what they did. Like I said,
Yeah,
a fairly
I agree.
straightforward call, and they didn't really fuck it up. Like, we don't do a lot of calls where there's not a lot of foul ups. And like,
Well, and how many allergic reactions have you done in the last year that required epi? Honestly.
none.
So it's really not a high volume call that you're doing, and you still didn't fuck it up.
Right. And they're a straight BLS crew, right? There's two
Right.
EMTs.
Who normally work with a paramedic. So
Right.
normally they're not even thinking like this.
Exactly.
So kudos to them.
Yeah, I think these guys did a phenomenal job, right? An absolutely phenomenal job. Do you guys have anything to add to this discussion before we wrap it up here for at least this portion of the evening?
I think they did great.
Phil,
They did
what do you have to add?
They did a phenomenal job.
Yeah, I think so.
They really did EMT things.
Hail to the champion, baby!
Butch, what do you say?
Yeah, I did a good job. To be in that position and, have somebody like that, they could be panicky and that patient, could have died and that's a bad day, but they did what they had to do and got the patient alive to the hospital and hopefully the patient had a good outcome afterwards.
Right.
Walked
And
out.
threw away the loofah.
And threw away the damn loofah, right? With gloves on,
Really?
like, ew. And then, I come back to what we talked about in the beginning. I think the other really thing that shined with these guys is they knew the pharmacology behind stuff, right? They saw, hey, all of the signs are pointing to this, even though there's no history of anything, right? Again, if it looks like a zebra, it probably is, right, in this situation. And they didn't wait on scene. They didn't call for a paramedic. They acted on what they saw and just did it. And we don't see that as BLS providers all that often anymore. Like, BLS providers still have to be confident in what they know. And they have
I also
the ability to act.
Go ahead, sorry.
No, go.
I loved that the second EMT wasn't quite on the same page and said something, and there was a conversation, so they're both on the same page moving forward.
Right.
I don't think that happens nearly enough.
I know. Especially in the, paramedic EMT realm. Like, paramedics just do shit, and the EMT's like, well, they're a paramedic. I'm just going to let them. And it's like, well, should you let them, though?
And that's my thing to EMTs when I'm training is, like, you don't have to know fully what they're doing, but, like, question them. Make them think twice about it, because you guys have the education behind it. So, like, hey, are you sure you want to use that med? And that'll make you pause for a second and be like, oh, do I?
Right.
Yeah, I do.
Yeah.
Let's go. And that's fine. That's all you need is that 2-second pause to be like, do I really want this?
Right. Right. And I think that conversation kind of is like part of your, like, especially like in this situation where the two EMTs had that conversation, you say one wasn't really sure, one was like all ready to do it. That's kind of like your med check, right? That's kind of like doing your 5 rights of med right then and there in like, okay, well, is this the right situation and the right patient to be utilizing this? Like, I kind of see where you're going, but really make me understand.
Right. So we're both on the same page and going forward.
Right. I think that's phenomenal,
Yeah,
as we all should be doing,
And he took the time to explain it, even though he has a critical patient, be like, this is what I'm seeing. This is what I want to do.
Right.
Cool. Let's go.
It takes 5 seconds.
Right.
5 seconds.
Instead of just being like, nope, I'm in charge. This is what I'm doing. Sit back.
Right. Deal with it. Go get me the stretcher.
Right.
Just so you could get out of here so I can do this without you watching. Yeah. But,
Buckle up, Buttercup. We're going on a ride.
Exactly. So, thank you guys again for joining us here on the podcast. We do have End of Tour coming up here in a second. I have a very interesting trivia game tonight for you guys.
God.
Maybe you will do better in this than the rest of
everybody.
I doubt it. I don't know. I would do awful in this, but I think it'll be fun.
Like I will too.
Yeah, who knows? But till next time, guys, thank you again for joining us here on the podcast. Again, if you want CME credit, go to Medic Materials CME Academy.thinkific.com. The link is in the description of this show. And if you're a BLS or a CFR provider here in New York State, even as a paramedic or an AEMT, you can get the CME credit for it. You just got to use it as additional credit. Yeah, this will be a core pharmacology lecture. So yeah, there you go. 1 hour of pharmacology. You could have just earned it. But yeah, till next time, guys, stay safe. And you know what, Emily, I'm going to give it to you tonight to do the honors.
Donuts.
Thank you for listening to today's episode. If you want more information on the podcast or to send us a call review, please visit medicmaterials.com/podcast. To learn more about earning continuing education credit from listening to this episode or others, check out Medic Materials CME Academy.thinkific.com. We appreciate your continued dedication towards EMS education and helping us advance the field. See you next time.